So, good morning, everyone. We are continuing with the head and neck, and this week we have laryngeal cancer. Good morning, everyone. Sorry, my YouTube is also opening. So, we'll start, and today we have Ronak, Shubham, and Gunjan who will be presenting the case. And I think Dr. Sharvani and Dr. Anuj Kumar will be there as moderators of the session. Start, please.
Good morning, sir. So, am I audible?
Yeah, now you're audible. You are not audible till now. Now you're audible.
Sorry, sir, you were having some connectivity issues. We connected again.
Okay. Yeah, please start.
Yes, sir. Good morning, everyone. My name is Gunjan. I, along with Dr. Ronak and Dr. Shubham, will be presenting virtual ward rounds on organ conservation, locally advanced laryngeal cancers. Case presentation. So, a 37-year-old male, a resident of West Bengal, a carpenter by occupation with no known comorbidities, presented with complaints of change in voice for 2 months, associated with hoarseness since 2 months. History of presenting illness. The patient was apparently well until 2 months back when he noticed change in voice and hoarseness in voice, which was insidious in onset and gradually progressive in nature. He also had intermittent cough, but it was not associated with food intake. He had also history of noisy breathing while sleeping. There was no history of aspiration, no history of difficulty in breathing or deglutition. There was no history of swelling over neck or excessive straining of voice. There was no history of trauma over the region or weight loss. There was no significant medical past history. He, however, had history of alcohol intake for 15 years, and he had history of cigarette smoking, 1 pack per day for 10 years, which amounts to 10 pack years. However, he reformed for the last 3 months. There was no significant family history. In clinical examination, general examination, the GC of patient was good with KPS 90. No pallor, icterus, clubbing, cyanosis, pedal edema, no generalized lymphadenopathy. On inspection, the mouth opening was adequate. No visible suspicious lesion in oral cavity. Buccal mucosa, gingival buccal sulcus, hard and soft palate, tonsils appear normal. No restriction or tongue movements. No visible neck swellings and no distended neck veins, and no stride. On palpation, inspection findings were confirmed, and there was no There was no lesion or induration in the oral cavity. No palpable cervical adenopathy. So just a second. Hopkins examination was done in which left cord was fixed and there was a lesion arising from the left false vocal cord. Investigations, we had routine lab investigations done, which were within normal limits, and viral markers were non-reactive. DL scopy was done, and they showed ulcerative lesion involving the left false vocal cord, involving the posterior one-third of the false vocal cord, and the ventricles. Interarytenoid and retroarytenoid were free. Subglottic appeared free, and hypopharynx was free. Left true vocal cord also appeared to be fixed, and biopsy was taken and sent for HPA. The image shown just now, shown alongside, is of a normal DL scopy findings. We can see anterior. Someone is editing. Can I please request Dr. Nimisha to undo the changes, please? This is also DL scopy finding showing vocal cord swelling. However, it is not of the patient. We have taken a different photograph, because since we were not able to find a photograph for the same patient. Yes.
Okay, Gunjan, can I stop you here? Just wanted to ask you something. Can you go to the history of presenting illness?
Yes, sir.
So, when you are taking the history of presenting illness, I think there is a way or a systematic way in which you should tell the negative history. So, you have asked about history of aspiration, difficulty in swallowing, and breathing, and then straining of voice. So if you are going, then first go locally, then regionally, and then for distant symptoms. I think we had discussed this in the previous case discussions also, because suddenly you tell there is no history of swelling over the neck. What you are referring to is not very clear, whether there is any, like, are you asking for any history of any regional adenopathy? Or when you talk about distant med, so go always in an order from local to regional to distant. So that is one point wanted to make here. And how did you ask for history of aspiration to the patient?
So whether there is a cough associated when he's intaking food or
Food also. Yeah,
yes,
so what did you exactly? Because if you have to write history of aspiration, you need to ask certain question to the patient in which you will get to know whether the patient is aspirating or not.
so
So that is important to take history for a patient who is presenting with hoarseness of voice.
yes, sir. So it would be pooling of saliva, and if he is having halitosis, or if he is.
So that is not.
How do you get history of pooling of saliva?
Ma'am, when he's sleeping, then is there a history of pooling of saliva?
No, what is pooling of saliva? Do you see it on history, or do you take the history about pooling of saliva, or do you see that pooling of saliva?
Ma'am, we see pooling of saliva.
How do you see the pooling of saliva?
Ma'am,
On
that's why-
examination, right?
Yes, ma'am.
How can you say that on sleeping there is pooling of saliva? Do you mean the saliva that is coming out from his mouth? That is not pooling of saliva, okay? Please remember that.
Yes, ma'am.
Yeah?
And
Okay,
also,
go ahead and answer Dr. Anuj's question.
So difference between drooling and pooling.
yeah.
Yes, sir.
Okay, carry on.
And Gunjan, so in this way, you can ask the patient like whether the patient chokes while eating or drinking, or whether the patient has a cough while he swallows any solid or liquid like that. You should ask for the history to at least understand whether there is some penetration or aspiration associated. Okay. And
Yes.
you also told about noisy breathing while sleeping. So, is this affecting the patient's sleep, or who is giving this history? Whether patient is giving the history or someone else? Because you also need to rule out stridor, right, when the patient is presenting to you in the OPD. So, what did you ask about this noisy breathing? Did you take any further details, and whether his sleep is affected because of that?
No, this history was not per se given by the patient. It would be given by the patient's attendant. And this, there was um no associated apnea with it. Matlab, there was no associated disturbed sleeping with it. So,
Okay,
I'm
so that is also important, because if the patient is telling that he is unable to sleep in the night, it may be because of some obstructive symptoms that he is having that is causing the stridor or the noisy breathing. So the history is very important when you take for any patient, but also for larynx in particular. Okay,
yes.
yeah, you can go ahead. Sorry, and come to the past. Can you come to the next slide also? Yeah,
Just
so
before, Anuj, just before
yeah.
related things. So which kind of food intake you will specifically ask for when they would have this coughing? And so is it solids or liquids? More with what?
The
So,
cough or the difficulty, the symptomatology is associated with which kind, consistency of food?
solid food.
Solid.
No.
Uh,
That's the whole point. We wanted to know whether
So
which
tell me
food,
some,
yeah, which
yeah,
food is more
Gunjan,
likely to go into the tract.
sorry.
Gunjan,
Yes, ma'am.
when you have a patient come to you and a patient complains of cough, what is the food that will go into the wrong passage? What consistency is likelier to go into the wrong passage?
Liquid consistency would
Yeah,
be more
correct.
likely.
So because see, on saliva, on taking in saliva, also the patient has cough. So
Yes,
that
ma'am.
itself will give you a hint that it is on taking liquids that the patient is likely to be symptomatic. All right.
Yes, ma'am.
And have you heard the word micro aspiration?
Yes, ma'am. Yes, sir.
What is that, and how will that, manifest? And when do we suspect patient is aspirating a little bit?
Sir,
Maybe Ronak or someone can tell. This requires clinical experience. Have you had your head neck posting, Gunjan?
Yes, sir.
Oh, she has had head neck posting. So tell me, when do we suspect or this thing that maybe this fellow is sort of aspirating without us realizing or without he realizing?
sir, if if there is halitosis, we can suspect that there could be microaspiration.
Halitosis. I think you're fixed on this halitosis. Sometimes oral cavity cancers, tongue cancers may have halitosis.
Okay.
So
If the patient has chronic cough, then we can suspect that it associated with halitosis. We can one of the reasons can
What?
be
1
microaspiration.
minute. What is halitosis?
Ma'am, it's a foul mouth breath. Foul
And
breath.
how does microaspiration cause foul breath?
Ma'am, over time, if there is
What happens?
actually halitosis happens if there is food that is stuck in the
See, sometimes it is not wrong to say I don't know. Okay.
yes, ma'am.
Instead of trying to guess.
Yeah.
Sir is asking you a very simple question. What is microaspiration? Polo, if you know it, if you don't
No,
know
ma'am.
it, we'll go.
No, ma'am.
We'll ask you only to find out and tell us.
Yes, ma'am.
Do you know it? What is microaspiration?
No, ma'am.
तो फिर क्यों ऐसे तुक्का मार रहे थे? चलो, go ahead. So we'll ask them only to find out instead of
Okay.
telling them.
yeah,
So
you
read
find
about
out what is microaspiration, how does it manifest, what are the implications, and then you write in the comment box of the YouTube live stream. Okay.
Okay, sir.
Okay, sir.
also silent aspiration. You can read about both of it.
Yes.
Yeah. Go ahead.
Go ahead.
So Gunjan, when you examined, can you go to that slide where you did about where you made the findings, previous slide? So you have very well examined the oral cavity, okay, and palpation has been done. But when it came to the actual examination of the larynx per se, we have only the finding of vocal cord is fixed. There is no other associated findings like whether you have examined the posterior pharyngeal wall, how you saw the epiglottis, what is the area. So that is completely missing, which is more important for a laryngeal cancer rather than what you mentioned about buccal mucosa. It is important, but then in Hopkins, you need to be more descriptive about the findings because you would have done Hopkins by yourself many times in the OPD. No, it is not that we go and see the lesion directly and just report findings of that. So there is a lack of proper examination findings in this case, ma'am. Ma'am, what do you think?
I agree with you, Anuj, because what has been written is essentially for everything about the oral cavity and the oropharynx, and there is nothing at all about the what you call very little. Hopkins examination, left cord fixed, lesion arising from left false cord. I think even Ronak, you should have helped her out, na? Is this enough to write in the Hopkins examination?
No, ma'am.
Is this all that you see?
No, ma'am. The structure.
Then,
So to be
okay, fine. Yeah,
So,
I think
so
Anuj
at
is
least
correct.
mention, even if it is not involved, you have to mention from what you start seeing when you are putting the Hopkins dot. So that is important, Gunjan. So yeah, you can go to the next slide. So again, here, this is not the picture of the patient, right? Like you told.
Yes, sir.
So yeah, so when you do the scopy, so what are the different types of scopy which you will do for a patient with laryngeal cancer? What if you don't have a Hopkins rod in your OPD? Because all the OPDs may not be having Hopkins. Then what are the other ways in which you can clearly examine a lesion? So can you tell some investigatory uh, like uh, things that you do when you want to examine this patient?
So mainly we have two types of laryngoscopies, direct and indirect. So in indirect laryngoscopy, laryngeal mirrors are also used for visualization of the larynx. So we can use laryngeal mirrors or
The laryngeal mirror, what kind of an image do you see? A real image or a virtual image?
so we
And what is the what you call laterality that you see? The right is right or right is left?
ma'am, the patient's right remains right and the patient's left remains left. However, the anterior and the posterior changes.
Oh, do you have lateral inversion or do you have supero-inferior inversion?
Ma'am, ma'am, in this.
No, Gunjan, again, so that is why it is important. See what you've written in your mirror examination. मिरर एग्जामिनेशन का टेबल दिखाओ तुमने अभी जो दिखाया देखो ये इन्वर्टेड इमेज दिखता है तुमको इनडायरेक्ट लैरिंगोस्कोपी पे which means what right is left is right है ना
Yes, ma'am. However, if ma'am, the patient's right would be right.
So please be clear about this when you see direct laryngoscopy, when you see indirect laryngoscopy, and what is Hopkins? Is it direct or indirect? Ronak,
Ma'am, Hopkins, with Hopkins, we can directly visualize the
really? Hopkins? Don't change my wordings. I am asking you, is Hopkins an indirect or a direct laryngoscopy?
What do you mean by indirect? What is the meaning of the term indirect?
the indirect. We are getting a reflection of the laryngeal structures from the mirror. So in case
So
of
what is Hopkins?
ma'am, we have a mirror and we shine light over the larynx and then we get the reflected image on
So
the object.
Hopkins is an indirect laryngoscopy.
Yes, ma'am, indirect. Yes, sir.
You wanted to ask something else?
So I just want to ask them, you said vocal cord is fixed. So what all things can result in fixation of vocal cord in general? Tell me, not just in this case. What all the things that can cause fixation of vocal cord?
So if there is any nerve involvement, if there are polyps involving the vocal cord, a mass basically.
Which nerve? Which nerve?
Recurrent laryngeal nerve, sir.
Okay. Okay. So other than recurrent laryngeal nerve, what else? So you said one is nerve injury.
Yes, sir. Nerve injury, if there is a mass involving the vocal cords.
So mass involving the vocal cord. So it
Yes.
just stops it from moving.
Yes, sir. If it has fixed, yes, sir.
So how does vocal cord moves? Along what axis? What are the things? In which direction it moves? When you have to show the movement with the cursor, you can show on this. You can show the cursor. You can show here the cursor. How does the vocal cord moves in this at this plane?
So I'm not able to.
You have seniors with you, exam going batch. Okay.
So there will be abduction and induction of the vocal cords.
At which end? Anterior end, posterior end?
Sir, at the posterior end, because at the.
Okay. Okay, carry on. Now, how do I erase what I did? Cursor. You carry on.
So we had a speech and swallow examination done for the patient, in which.
So 1 minute, Gunjan, before you come to the speech and swallow evaluation, go back to your own examination. That is most important, because I want to know what you have seen on this patient other than this left cord fixed and lesion arising from the left false vocal cord. Don't see, this is what happens na. तुमने क्यों DL Scopy का report copy किया? Acha, now you've marked it very nicely. This picture looks very good. It's a very good picture. But I want you to tell me, because what we want from you is what it is that you have seen when you have done the examination. I don't expect you to use the mirror today because none of you know how to use the mirror.
Okay.
But what have you seen on Hopkins?
Yes, ma'am.
यही सारा चीज तुमको Hopkins में भी appreciate करना चाहिए, except for the subglottics. Perhaps you will not be able to see. You may not be able to, essentially the subglottis. Other than that, you will be able to see everything. So were you able to appreciate all those things on your Hopkins evaluation?
Yes, ma'am. I'll just once tell the indirect laryngoscopic findings. Ma'am, when we do the examination, the first thing we can actually appreciate is the base of the tongue and the vallicula, the median and lateral glossoepiglottic fold. And then in the larynx, we will see the pyriform fossa and
No, the larynx, the pyriform fossa is not a part of the larynx. तुमने ये
it's
जैसे ही बोलेगा तो.
I'm
So
sorry.
what will you see? You will next see the epiglottis very clearly.
Yes, ma'am. Epiglottis. Yes,
So
ma'am.
what was the epiglottis? Was it normal, abnormal?
Ma'am, it was normal.
Okay. Then after the epiglottis, if you see, then what will you see?
Ma'am, in the epiglottis, then we continues as the eriepiglottic fold. And the
After that, what structure do you see clearly? If you can do the Hopkins,
ma'am, then the false
you will see both cords and the false cords.
cords. Yes, ma'am.
And then after that, if you go a little beyond and your patient is still not gagging, then you may see one or two thyroid tracheal rings.
Yes, ma'am.
Not thyroid, tracheal rings. And then on the sides, you will see the pyriform fossa, right?
Yes.
And in all this, you're going from supraglottis to glottis and some cases subglottis. So you have to remember it like that. And that's how you need to draw your diagrams and be sure of what it is that you're seeing. So you see the epiglottis, the eriepiglottic folds, the true cords, the false cords, the pyriform sinuses on both sides. And then you see the supraglottis because you have seen the lingual, what you call the glottic surface of your epiglottis, the airy epiglottic folds, and your false cords. Okay.
Yes.
Now go to the next picture, and then you can say whether your glottis, your true cords are fixed or not. And sir, was she able to tell you the reasons for which the cord can be fixed?
Yeah, I think more or less she could say
Okay.
it. And the other thing you all should know, which are the cancers in the laryngopharynx region which can be missed or not visualized on, say, direct or indirect laryngoscopy.
So where is that cancer located usually?
And in early stages, of course, in very advanced, no cancer will be hidden. But in early stages, which is the cancer, at what site that may be missed?
So a common site for unknown primary, which becomes a primary because you then detect it. So which is the site in the larynx hypopharynx?
Ma'am, in indirect laryngoscopy, we are not able to visualize the apex of the piriform sinus and the post.
So that is one site that is mixed any which way. So that is the apex of the piriform sinus. Okay, go
ma'am,
next.
Posterior cricoid region. And ma'am,
Post-cricoid, you don't go through it with your DL scopy or your thing. Ideally for post-cricoid, what is the investigation of choice? For mucosal examination, what would you want to do?
not sure, ma'am.
Bolo, Ronak,
We can get an MR imaging or
please,
No.
please. We are talking about mucosal examination
ma'am,
without
upper
any
GI and
imaging. What will you do?
upper GI endoscopy we can
Yeah,
do.
okay, yeah.
So the other thing is, if suppose there is a piriform lesion, piriform sinus, and you, because of pooling of saliva, you can't see the cancer. What could be the other manifestation, overt or subtle, that there is some mass there?
Sir, there is a loss of laryngeal click. That is one clinical examination finding that we can have that gives us a indication that there is a laryngeal mass, loss of larynx, but that can be one finding.
Loss of what?
Ma'am, laryngeal click, that when we do on
What is
clinical,
click? Laryngeal
ma'am,
click kya hota hai?
ma'am, clinically when we move the, yeah, ma'am, the thyroid cartilage externally, ma'am, there is a
What is
click.
click, man? It is called as laryngeal crepitus.
Crepitus, yeah. I think there must be new tech terminology they use. But that happens in very advanced cancer.
Very advanced stage.
Yeah, that is not, that is a very advanced stage. And you should know what is the cause. Like when the cord gets fixed, why it gets fixed. When you a loss of laryngeal crepitus, what is the reason for that? Okay, all those things you should be aware. I think today let us focus on examination findings. Very important because larynx and pharynx examination. Rest we of course we will discuss whatever we can discuss. But I think Sharmani, good, you and Anuj are taking them through the examination findings. That's very important. Carry on.
Sir, can I make a point here? This is Dr. Monali.
Yes, Monali. Yeah, please.
So for the examination, I just wanted to add one thing, that when you are saying that the vocal cord is fixed, so you have to see whether the opposite vocal cord is able to compensate for that. That is one of the important indication that whether the patient is going to aspirate or not. So that you have to mention whenever you are mentioning one cord is fixed. That's the only thing I wanted to add.
Yeah, that is important, especially those who have it's non-malignant causes over a long period of time. They sort of manage their voice. They get a reasonably better quality of voice, not of course as it was original, because the other cord compensates for it to some extent. But in cancer, I don't think does it happen, Sharmani, that the normal cord will compensate for it, because this happens over a period of months, not over a period of years.
So often, most often, you will not see it happening in cancers. It does not happen in cancers except post-treatment. Sometimes this can happen where the opposite cord may compensate for a slowly moving. The normal cord can compensate for a slowly moving opposite cord, but this is usually seen post-treatment and not really when there is a cancer inside.
Yeah. Good.
So the thing is that you have to mention that, because so the patient must be coming for.
Monali, you're making a very pertinent point, but please understand that these people have to first appreciate changes in the motion of the cord. After that comes about compensation, because I don't think they can even make a comment about whether this cord is fixed or semi-fixed, that kind of thing, So then this compensation
I couldn't hear, ma'am.
Yeah, Sharvani, we lost
Okay.
your
I
voice.
missed your voice. Yeah, we missed your voice.
I think all of us missed your voice. So, Anuj, I think you're with Sharvani. No, Sharvani, we can't hear you. I think your
No,
signal.
so what I was saying is what Monali is saying is very pertinent, but that is something that you have to look for after treatment because the cord may get fibrosed at that time. And then it is important to see whether compensation is happening or not so that you can prevent aspiration or you need to intervene. That is what
Very
it will help you decide.
excellent points.
Um, Can I continue?
Yeah, please continue.
This is
Sorry, we are interrupting so much, but these are very important points. Unless until you understand them, no, this will carry on.
A speech and swallow examination was done. They had voice different scores were taken. Functional oral intake scale was 7, and aspiration risk was low, and it was a clinically functional swallow with moderate hoarseness of voice. Biopsy was taken.
Again, Gunjan, you have sent the patient for speech evaluation,
Yes, sir.
but how do you assess? So this is what the findings that they have mentioned, and I don't think most of it is relevant when we take the history, the functional oral intake scale and Lipstick Pearson score and all. Okay, so what you need to understand is that what will you advise your patient? So how will you like assess aspiration? Okay, so that you should know, and what is fees and what is VFSS? Have you heard? So, how do you objectively evaluate swallowing? That is my question. So, what are the ways in which you can evaluate swallowing? So, can you tell the different ways?
So I haven't personally done anything in the OPD myself, but I know about face and video fiber optic endoscopic evaluation for swallowing.
Yeah. So what is the difference between the two? Like, I want to ask you, what do you see in fees? It is not that we will do it, but still we will have to know what is being done there. And also in VFSS. So, what is VFSS first of all?
So it's video fluoroscopic swallowing study,
Yeah,
in
yeah,
which
good. So,
it's basic barium swallow study.
okay, so how is it different? So you have the patient has been evaluated in the speech language pathology OPD, and they
Yes,
have
sir.
done a FEES, which is
Yes, sir.
functional endoscopic evaluation of swallow. So, why did this patient not undergo a VFS? And do you think VFS is important before you proceed further? How is it different?
So in VFSS, we can real time see the uh, dynamic, but the swallowing motion. But
Okay, so
maybe
I think first of all, if you have a chance, get to see how a fees is done and what happens in VFS also, then you will not forget. Okay, so the main difference I think you should know between the two. Do you see all the phases of swallowing in a functional endoscopic evaluation?
1 minute, Anuj, since you're
Yeah,
asking this question, I would also like to ask is in which cases you will not do a fees.
yeah, ma'am.
If you know that, then you will be able to answer Dr. Anuj's question. And the other question that I want Ronak to answer is what is the difference between a VFS and VFS or MBS and a ordinary barium swallow?
Ma'am, in video fluoroscopic swallowing study, we do it's an X-ray study, and real time we see the phases of swallowing. And ma'am, the other in a case of barium swallow, ma'am, I don't know the exact difference.
So what is this? What is this swallow? How is it different from a barium swallow? In barium swallow also you can take cinephims and thing what you call and stills. No, you can take and you can understand whether the patient is swallowing or whether the patient is aspirating. There is penetration. You can understand. So what is the difference between a video fluoroscopic assessment or an MBS and an ordinary barium swallow? This is also very important. Please write down at that as another question to answer.
Ma'am, the
Okay.
consistency of food,
Yeah.
like consistency of the swallows that we give, semis.
Of the bolus that you mean?
Yes, ma'am. It
Of
can
the swallows, of the bolus.
bolus,
Okay.
yes, different
Yeah.
consistency.
No, there is something else that is very different. The number of frames per second, the speed of acquisition, all that is there. So please find out what are the differences between a thing and a barium swallow. And okay, and about fees also, in which cases will you not do a fees? That is also important. No, otherwise you could use a fees for estimation of everybody's functionality, but you don't do it in certain cases. Which are those cases is also important to know. Correct? Because this is first you've done a clinical evaluation, then you've done an examination under anesthesia, which in this case is a DL scopy. Then you've done your other imaging ancillary tests like your speech swallowing assessments, either with a video fluoroscopic assessment or an MBS or an FEES. And then you have come to the, what is your final assessment of this particular patient?
Ma'am, it was a clinically functional swallow with moderate hoarseness of voice. Final assessment are we talking about in terms of staging, ma'am?
Yeah, staging, what is it? Then you've done clinical evaluate. Is there any other question that Anuj or Monali would like to ask for the clinical assessment of the case?
Did you also see like read about something called PAS, because that is not mentioned? Ronak, what is PAS?
So it's a penetration aspiration scale, and
What is SS?
yes, ma'am.
PA नहीं है, उसके बाद और भी कुछ है ना?
Penetration aspiration scale, ma'am.
Then PA that is. What about the S?
Ma'am, it's penetration aspiration scale.
Okay, nothing else in between. Is there a single S or a double S? See, I'm telling you again and again, Ronak. So then how do you assess in the scale? Actually, Gunjan had put it up. Gunjan, go back to your slides.
Yes, ma'am.
Next, click karo.
No, I think that is the
Okay,
voice
she's not
that
put.
she has
No, she's not put. Okay, yeah, okay. Yeah. The
Yeah.
network. The network is very bad at my end. Yeah.
So
Okay.
read about that also, Ronak and others. Actually, others from exam going batch can also answer only. Yeah. Okay, go ahead.
Monali, anything?
I think what Anuj said, all the exam going batch should be there and they should be logged in and we can ask them also questions. So it is not only the team which is presenting. Okay.
When the patient had an MRI neck done from outside, which was reviewed in TMH, there was an ill-defined altered signal intensity involving the left vocal cord and left paraglottic space, which was extending to the anterior and the posterior commissure. CECT neck was done here. It had a heterogeneously enhancing ulcerative lesion in the left posterior 1/3 of the false vocal cord, which was extending to the true vocal cord. The left arytenoid cartilage was involved. Epiglottis, pre-epiglottic space, vallicular hyoid, medial wall and lateral wall of PFS and AE folds were not involved. The paraglottic space, anterior and posterior commissure, the posterior cricoid, subglottic and prevertebral fascia were also not involved. We had an NCCT thorax done, which showed no suspicious pulmonary nodules. When these were the images from the CECT.
Yeah, so 1 minute. So I think Gunjan and
Yes.
then Ronak, will you please identify the structures on this slice of the CT?
Yes, sir. What do you want?
Yes, ma'am. So, no
Cursor
point.
is- Ma'am, actually, with the cursor, we are having not able to get the cursor on the screen.
Very good. You can go to the next slide.
And we have put images where we have pointed out these structures in a normal finding in the subsequent slides, ma'am.
That's
You can
easiest.
show
No,
it
I
here
want you to
also.
tell. I want you
Yeah,
to
yeah,
tell
yeah.
it without seeing those markings.
So
So we
what
will
we see here, prominent finding.
So we can see the bulging over the left vocal cord region. So that would be the
How
prominent.
do you know that this is the level of the vocal cord? What other structures can you see?
Ma'am, we can see the arytenoid. We can see the thyroid cartilage and the arytenoids.
So what tells you that this is the level of the vocal cord? How do you identify the level of the vocal cords on your CT slices?
Ma'am,
Anybody else?
the tip
Yeah,
of
Bolo.
the arytenoid corresponds to the vocal folds, and when we have the muscular process or if it is increasing in the width, the arytenoids, then it is at the level of the true vocal folds now.
So when you see the arytenoids, that's when you begin to see your true vocal cords. All right. Now, what are the vessels that you can see on this?
Ma'am, we can see
The internal carotid artery and the internal jugular vein, ma'am.
Okay.
In the
ठीक है अभी चलो आगे. So this is before your carotid has actually split. So you're seeing it's already split, right?
yes,
yes, ma'am.
Yeah. Okay.
Gunjan, can you show the anterior commissure and the cricoid also here with the cursor?
No cursor they're saying.
Then it is.
So what would you do? Would you do a CT scan or an MRI in a patient like this?
ma'am, CT scan.
Why not an MR?
Ma'am, MR is usually done in patients whom we are not sure of whether the cartilage is involved or not, or in the early, yes, ma'am. Basically, if we are not sure if the cartilage is involved or not. So in this case, we were pretty sure that the left arytenoid cartilage is involved, and we did not see any involvement of the thyroid cartilage.
What should be the slice thickness of CT? It can be just standard, or what is the protocol?
So I'm not sure.
You all read, anyone can say, tell when you see. So it's like any other, you were doing a nasopharynx or a glottis CT, will it be same or any different? So you all please read and write in the comment box.
Yes, sir. So these were the MR images of the patient which were available. So we can see the bulge in the left vocal cords. This is the coronal T1 post contrast image. And we have the arrow marked. The final diagnosis was squamous cell carcinoma of the supraglottic larynx. C T3N0M0. T3 because it was limited to larynx with vocal cord fixation. However, there was no involvement of postcricoid, paraglottic, or the prearyglottic space, or the inner cortex of the thyroid cartilage. We went ahead. The plan was for radical radiotherapy with concurrent chemotherapy. The patient was advised dental prophylaxis and nutritionist reference was given.
Gunjan, so with your diagnosis,
Yes, sir.
so what are the subsites of the supraglottis?
So supraglottis is suprahyoid, infrahyoid epiglottis, the aryepiglottic folds, the arytenoids, and the false vocal cord.
And how is it staged as a T3? Can you explain how did you arrive at T3 as a diagnosis?
So the tumor was limited to the larynx with the vocal cord fixation.
What else can cause a T3 in the supraglottis?
If there is
Can you tell?
So if there is involvement of posterior cricoid or the paraglottic space or the periepiglottic space, or if there is the inner cortex of thyroid cartilage is involved.
Okay. So for this patient, it is because of vocal cord fixity that you have called it as T3.
Yes, sir.
Okay.
So coming to etiology, pre-discussion for etiology, predisposing factors, alcohol and tobacco are the most common.
Sir and ma'am, can we discuss about the management rather than them presenting their slides of etiology, etc.?
I would
Or is
agree
it
with you.
Yeah.
I don't know. Yeah.
Yeah, you can just quickly 1 second just show the slide since you have made it. On the YouTube, people will just see this only later on when they are going through. And I don't think maybe we'll be able to complete the discussion today, but I think the evaluation part was very important. So maybe this will spill over to next week, and we will also cover the early glottic cancer because that I think they also has a lot of nuances. So this they can just quickly just show the slide, tell the salient points, one line, and then we will cover as much as we can today and then next week.
So just one line about each slide. There's a combined effect of tobacco and alcohol. It's a multiplicative risk factor for laryngeal cancers. We have slides for anatomy. Basically, larynx divided into supraglottic, glottic, and subglottic regions. The pattern of spread for each site of larynx, supraglottic, glottic, and subglottic. Glottic carcinomas, and then the lymphatic spread.
We have AGCC 8th edition staging slide.
Sorry, is that Shubham who is now coming?
Yes, sir, I'm sure.
Okay.
Got this. Subglottis.
I think the staging and all we can do next time. Today, just the management of this case, so locally advanced conservation, that we can discuss. Many of these aspects we've already discussed. So you come to the management of this case.
So I'll be talking about the management. I'll just go through the organ preservation. The available treatment.
Ronak, I think you can speak about what patient you have discussed today rather than having a generalized discussion. So this patient who is in front of you, you
Yes,
have diagnosed it as T3N0. For this patient, how will you counsel the patient? How will you manage this patient?
Okay. So the patient is a 37-year-old male who is has a good KPS.
No. So 1 minute. So, Ronak, when you sum up a case and present it, you will say a 37-year-old male in good general condition or performance status 1 with a dash. So it is a CA glottic larynx T3N0M0. That's over.
Yes, sir.
Then you will come to your management. So now tell us your management. So we know that this is a glottic larynx T3N0M0, right?
Yes, sir. So the in this case, this is a locally advanced supraglottic laryngeal carcinoma. So the available treatment modalities we'll have is either a total laryngectomy with or without postoperative RT, or we'll go for the organ preservation strategies, which I've mentioned can be conservative surgery, definitive RT, induction chemotherapy followed by RT, concurrent chemotherapy and RT, or we can have targeted therapies and altered fractionation.
No, so in the
So,
exam,
Ronak,
this is a theory paper.
Yes.
Okay, what you're talking is your theory.
Yes, sir.
Tell us in the practice, in the practical setting, what would you want to do for this patient?
So, ma'am, since as I mentioned, the age and the good performance status, and we can offer organ preservation to this patient, we'll be counseling about it.
So surgical or non-surgical organ
Ma'am,
conservation?
non-surgical, I would go ahead with.
And what would be your non-surgical conservation for this patient?
Ma'am, in this case, we would go for a concurrent chemotherapy along with radiotherapy. And
Okay.
yes, ma'am. In this,
Then keep talking till someone stops you.
okay, ma'am. So we'll go for concurrent CTRT, and then we'll assess the response. So
Bas ho gaya. This is how you will treat this patient. What about the chemotherapy? What about the radiotherapy? What are the radiotherapy volumes? How will you counsel the patient? What are your radiotherapy volumes? What is the technique? What is the dose? What is the anticipated sequelae to treatment? And then your follow-up schedule.
okay. So talking about the radiotherapy, ma'am, we would go with intensity modulated RT, and we'll try to.
Do you need to counsel the patient about anything? Do you need to send the patient across for any kind of prophylaxis,
Yes,
dental prophylaxis, nutritional counseling, speech language therapist?
Yes, ma'am. Speech.
You know, रौनक मेरे को ऐसे लग रहा है सुन के कि कभी तुमने हेड नेक पोस्टिंग किया ही नहीं, तो बताओ सब कुछ.
We'll counsel the patient about the treatment options that we are going, and we'll be telling them that we're going ahead with concurrent CTRT, but sending the patient for dental evaluation.
What is the duration of the treatment? What are the anticipated side effects? ये सब बताना पड़ता है ना काउंसलिंग के टाइम पे.
So, ma'am, we'll be.
You have a slide on counseling. What are the issues, aspects that will be covered? I think that is important. On all of these cases, you should have a slide, not just for count. Just bullet points. What all aspects will be covered in counseling? He may be having a life-changing treatment.
Yes.
Okay. Although it is life-saving, but it could be life-changing also. So, what are the aspects that will be covered during the counseling? Do you have a slide by any chance?
No, sir, not particularly.
So I think in future presentation, all of you, when you have a case, when you discuss the case with them, it's a shared decision making, they have a choice. So what are the points that will be covered in the counseling session?
So we will be explaining the patient about the treatment that we are offering, and then the duration of radiotherapy. It will be spanning over 6 weeks. We'll be delivering radiotherapy to a dose of 66.
So when you explain to the patient the pros and cons of your 1 and 2, okay? So
Yes.
what are this thing? Do you have a slide on the pros and cons between the two approaches?
So we have mostly focused on organ preservation. So
Okay, no, that's true. But at least one, if someone asks you, okay, why do you want to give organ preservation? Why not just laryngectomy and if required, then post-op radiotherapy? So,
yeah. So the impact on quality of life that a laryngectomy will have on this patient who is 37
that
years.
is one thing. Okay. So you want to minimize the impact on quality of life?
Yes, quality of life. He'll losing all the laryngeal functions, where we can and preserve those functions with an organ preservation approach. We can have a normal speech, swallow, and phonation with organ preservation. So that is one of the major things that we'll be focusing on, and why we are going ahead with CTRT rather than laryngectomy in this patient.
And if I were the patient, I will ask you, okay, doctor, yes, I would like to keep my speech and voice, but are you sure my chances of cure will not be, affected? So what will you tell the patient? Forget about the trial. So patient, you don't show them the meta-analysis or anything else.
Yes, sir. Yes, sir.
So I am asking you, doctor, thank you. You said you can save my, voice, but I'm sure it is not affecting my chance of cure. I want to live. What will you tell the patient?
So, we'll tell them that it has a better cure rate than compared to laryngectomy, the organ preservation.
That is where you're making a mistake. Don't say that. Is it because they have a better rate with CTRT, or is it for some other reason that you're offering CTRT?
Ma'am, the major reason is organ preservation.
Yeah, so it is not. Actually, it is the other way around. Surgery followed by adjuvant therapy has the best outcomes. So please be cautious, careful, and informed about what you are going to tell patients. All right.
Yes, sir.
So the approach is organ preservation with surgery reserved for
Salvage surgery.
okay. So it's not that okay, you have to tell the patient, okay, there are two approaches. Okay, the best sure shot method is this, but that's the downside of it. The other is we can do this, and studies have shown. So you should know when you. So this is a very difficult choice for a patient. If you're telling someone, one is on one end you have this is a brutal treatment, you remove the voice box and everything, and you can have artificial phonation. On the other hand, we will attempt to save that.
Yes.
So this is a very important discussion which you have. Okay. In many cancers, we don't have this sort of nuanced discussion and you put the burden on the patient and it's a shared decision making. But wherever it is, you should know what points have to be said in what manner, which is comprehensible to the patient, and they can make a decision.
Yes.
So Ronak, one more thing is, for example, if this patient had aspiration, clinical aspiration, and his PA score is 8, for example.
Yes.
So at this point, the stage remains the same. It's a T3 and 0. And at this point, so how will you counsel the patient? And how will you tell about organ preservation versus surgery at this point of time?
So like this is before RT, the patient has a penetration aspiration score of 8. So at this point, sir, the laryngeal function is not like the swallowing function is not there, sir. So we would advise, and there is no functional swallow, so we'll advise the patient for a laryngectomy in this case with postoperative RT because he has aspiration.
When else will you counsel the patient for surgery other than like now you told aspiration? So in a dysfunctional larynx,
Yeah. So if
you will count.
dysfunction and so from the staging point of view, if the laryngeal framework is lost, so the cartilage invasion is there, gross cartilage invasion is there. So in those cases also, we would advise for a laryngectomy with adjuvant RT. Sir.
Cartilage invasion, when you tell, is it the inner cortex or the outer cortex?
Lost cartilage invasion. Sir.
No, so whether it is inner or outer cortex, whether it is
Outer
your-
cortex invasion.
Right.
Yes, sir. T4A, sir.
So it is not just organ preservation, organ and function preservation. Okay, that is very important. Okay, so whenever you suspect that you might be able to conserve the organ, but the function would be really impaired or that it can actually cause more problems, then there's no point in preserving that organ.
Yes, sir.
So can you quickly tell about the radiation dose you will give
So
for
I
this
think
patient?
Anuj, what we will do, we have just I think how many 2-3 minutes left. So
Yeah,
just
sir, only 2 minutes.
salient points today, and then we will continue in the next this thing. So I think they are talking about
Okay, sir.
affecting treatment decision. Maybe just today let us finish here, and then next week, since we are talking of larynx, let us have one case of early glottic larynx where the different surgical and radiation approaches would be there. Then we will cover larynx, and then we will come back to either oropharynx or hypopharynx.
Okay, sir.
So, Ronak, in few minutes, just the factors affecting treatment decision. That's what you were showing. Huh?
Yes, sir. So the treatment decision depends upon multiple factors, patient, disease, and treatment related. So they have I mentioned age, performance status, comorbidity. For disease related, the stage side volume, cord mobility, and the treatment related factors, which include physician expertise, feasibility. So
just go back to your previous slide. See, when you say that things are very important, you should highlight, just bold them. Like reliability for follow-up. A patient who is not reliable for follow-up, I mean, that patient and the occupation, suppose someone has an occupation, they have to speak. So I think the important points you should, highlight. Carry on.
So the eligibility criteria for larynx preservation, laryngeal or hypopharyngeal tumors T2 to T3 up to T4 without massive cartilage invasion or soft tissue extension and without laryngeal dysfunction. That is, the patient is requiring a tracheostomy or a nasogastric tube, or there is inhalational pneumonia, less than 70 years or fit for chemotherapy and a good performance status. And when to not consider is if there is gross invasion, dysfunctional larynx, not willing for RT or poor candidate for chemotherapy, or there is severe airway compromise. So the endpoints of organ conservation include local control, cost-specific survival should be improved, and an overall survival should be improved, and the preservation of the function of larynx, which includes voice preservation, preservation of swallowing, respiration, reduced chances of aspiration, and an acceptable quality of life. These together, there is a disease control and the preservation of function of the larynx. So then I have.
So I think now we'll stop here, go back to the previous slide. That's very important. I think you have summarized it everywhere. That is the goal for, organ conservation. So actually you should call it organ and function, preservation. So that is what it is. And I think next week we will discuss the rest of this locally advanced laryngeal cancer as well as early glottic cancer. And thank you. Today we spent a lot of time on how to evaluate a larynx in a history examination finding as well as the scopy for that. Thank you. We'll end the meeting.
Thank you, sir.
Thank you.